Yes. Good morning to all of delegates and faculty members. Am I audible?
You are very much audible, Dr. Sumit.
Okay. Uh, in today's module 5, I am Dr. Sumit Patil. I am presenting the surgical anatomy of cochlea and round window. So first we will see about this dry temporal bone, in which we can visualize this medial wall. In this medial wall, it is uh, also the lateral boundary of that of the inner ear. Here we can see these main features. These are the promontory, this one. Then fenestra vestibuli, that is the oval window, and fenestra cochlea, that is our round window. So this promontory, it is a rounded prominence which is followed by the small grooves that lodge the nerves of tympanic plexus. Deep to this lies the basal turn of the cochlea. Here we can see the pyramidal eminence which lies the posterior to this promontory. This pyramidal eminence, it is separated by a depression. Here we can see small depression, that is the sinus tympani. So first we will see this fenestra vestibuli. So that is a kidney shaped opening which is situated supero-posteriorly to this promontory, leading to the tympanic cavity to vestibule of internal ear. It is occupied by that of the foot plate of the stapes. This is the fenestra cochlea, that is the round window. It lies posterior to this promontory. Round window lies completely under the overhanging edge of the promontory in deep hollow niche. In dried specimen, it opens antero-superiorly from tympanic cavity to scala tympani of the cochlea. If we see this promontory, it gives two posterior extension. This is the posterior part. We will get this two posterior extension. One, this is the subiculum of the promontory. This subiculum, it separates this round window from this sinus tympani. And another extension that goes from this promontory to the posterior aspect, it reaches up to the base of this uh, pyramidal eminence. This is the ponticulus. Now just we will see these all features which are seen in this dry bone. We will see endoscopically like this one. So here this is the sinus tympani, this main important rounded structure, that is the promontory. Here we will get this round window. From promontory we are getting these two extensions, that is the ponticulus and this is the subiculum, which are bounding this sinus tympani. Here it is a pyramidal eminence. Here is the stapes. Deep to this stapes is the oval window. This round window, it has an important anatomical structures which imply the surgical concern. We discuss this round window under these three important headings: round window neck, round window skeleton, and round window membrane. First, we will see this round window neck. So round window neck, it is usually triangular in shape. So here we can see this triangular structure, that is the round window neck. And here it is this round window neck. If we see the boundaries of this round window, so it is postero-superiorly, it is bounded by the subiculum. So this is the subiculum, and antero-inferiorly, it is bounded by the funiculus. Now coming to the bony ridges of this round window neck. This fustis, it is a constant smooth bony column forming the floor of the round window neck. Here it is a fustis, this bony projection, that is a fustis. The direction of this fustis leads to the scala tympani of this cochlea. It is a strong support to the round window membrane. This round window membrane, it is strongly supported by this fustis. Then another structure, that is the funiculus. So funiculus, it is a bony ridge which is connecting the basal part of the promontory to the jugular bulb. This is the promontory from here, this portion, it is going to the jugular bulb. This is the funiculus. This funiculus, it also separates these two important spaces. Inferior retrotympanium, it is separated from this hypotympanium. In between we get this funiculus. Now coming to the spaces of this round window neck. So first there is a sinus subtympanicus. So sinus subtympanicus, it is a space which lies between the subiculum and funiculus. So here this violet colored labeled as SS, that is the sinus subtympanicus, which is lies between this subiculum and funiculus. This sinus subtympanicus, it is the space which lies just below that of the sinus tympanicus. So this is our sinus tympanicus. Below that, this is a sinus subtympanicus. The another space, that is the area concamerata of the proctor. It is an anatomical area which is composed by the bony cells which are developed around the fustis. So this area which is developed by the side of this fustis, that is the area concamerata of this proctor. Subcochlear canaculus, it is a deep tunnel which lies between the fustis and funiculus. So blue arrow to this structure, that is the subcochlear canaculus. It lies between this fustis and funiculus. Now coming to the round window skeleton. Round window skeleton, here we can get this round window and the bony portions which lie by the side of this round window, that are the tegmen of this promontory. Then there is a posterior pillar and this is the anterior pillar. The tegmen, this tegmen of round window, it is defined as the oblique dorsolateral edge of the promontory forming the convex edge over the entrance of the round window. Configuration of the tegmen of round window may influence the surgical view of the round window membrane. This posterior pillar, it is located near the bony edge of round window on posterior-superior aspect, forming an acute angle to the tegmen. It is forming that acute angle. This anterior pillar, it is located antero-superior aspect of the round window neck, fusing with the anterior portion of the tegmen. Now coming to the round window membrane. This round window membrane, it is a concave. This concave portion, it is facing on the tympanic cavity. As this tympanic membrane, it consists of 3 layers. Likewise, this round window membrane, it will also consist of 3 layers. The outer layer, it consists lined by that of the cuboidal cells, that the same epithelium which is lining that of the tympanic cavity. The middle layer, that will be the connective tissue layer, and the inner layer, that is also lined by that of the epithelium. That lining epithelium is the simple squamous epithelium. This simple squamous epithelium which is lining that of the internal ear cavity. If we see roughly the thickness of this round window membrane, it is 70 micrometer. Its length, it is about 1.7 mm, while the width, it is 1.3 mm. So here it is our round window. So these are the important structures which lie by the side of this round window. The facial nerve, which is superiorly also on the posterior aspect. This oval window, it lies 2 to 4 mm above to this round window, while the jugular bulb, it lies 2 to 4 mm just below to that round window. Now coming to the exposure of this round window. To view the complete round window, the overhang uh, superiorly should be removed. After removal of this overhang, we can see the white color pseudomembrane. So there are the two layers are there. So first we will see this pseudomembrane, which is white colored. After removal of this pseudomembrane, we will get the true membrane. This is the true membrane, which is dark gray colored. The superior border of this round window is closest to that of the basilar membrane and osseous spiral lamina of this cochlea. Now coming to the anatomy of the cochlea. So this bony labyrinth, it consists of these three important parts: cochlea, vestibule, and semicircular canals. So this is the cochlea. This cochlea is the anterior part. This vestibule, it lies in the middle part, and posteriorly we have these semicircular canals. So all this structure, it forms the internal ear. So this, on the medial wall of this tympanic cavity, we get this prominence. This is the promontory. This prominence, it is formed by this basal circle of this cochlea. While this is the oval window and this is the round window, we will get this oval window and round window. So on this portion, this is related with this vestibule and basal turn of this cochlea. This portion will come on the medial wall of the middle ear. So cochlea, it will consist of 2.5 to 2 and 3/4 turns. So these are 2.5 to 2 and 3/4 turns. The length of this cochlear duct, it is about 28 to 35 mm. If we see its diameter from this apex to the base, this is about 5 mm. If we complete diameter, it will be roughly 9 mm. So this cochlear canal, it is divided into two parts by one osseous spiral lamina. So inside this cochlea, one osseous spiral lamina is there. This osseous spiral lamina, it will divide this canal into scala vestibuli. This scala vestibuli, it lies above, and this scala tympani, it will lie below. These relations, these are related with this basal turn of this cochlea. So this bony portion, it is lined by that of the epithelial linings, so that we will get these two cavities. So scala vestibuli, it is related with this oval window, while that of the scala tympani, it is related with this round window. So footplate, it will footplate of the stapes, it is present on this round window. So what are the vibrations that will come, that will be transferred into this scala vestibuli, so that will produce the wave movement in the endolymph, which is present inside. These waves that will go through this scala vestibuli, and the apex, there are the small foraminas. Through that, it is connected with that of the scala tympani, and that waves that will be again transmitted to that of the scala tympani. Now this is the cut section of this cochlea. When we take this cut section, we know that there are the two important cavities, scala vestibuli and scala tympani. But in middle, we get this cochlear duct. So this cochlear duct, it occupies the middle part of the cochlear canal between scala vestibula and scala tympani. It is triangular in cross section. If we see the floor of this cochlear duct, it is formed by that of the basilar membrane. This is basilar membrane, and the roof, it is formed by the vestibular membrane. This basilar membrane, it supports the spiral organ of the corti. It consists of hair cells. It consists of these hair cells, pillar cells, and supporting cells. So this portion, that is the organ of corti. So these, there are these hair cells. Two types of the hair cells are there: outer hair cells and inner hair cells. These hair cells have these stereocelli. The length of the stereocelli in the outer hair cells, this is longer as compared to the this inner hair cells. Here are, these are the pillar cells, and we got this supportive cells. The peripheral process of these bipolar cells located in the spiral ganglions are connected to the hair cells. So we have this spiral ganglion, and these processes, these are connected to that of these hair cells. And these stereocelli of these hair cells, these are projected into a gelatinous material, that is the tectorial membrane. The spiral ganglion, it is located at the base of this osseous spiral lamina. This is the osseous spiral lamina, and this is its base. And if we see this central bony portion, that is called as the modulus. So this, from this we get this cochlear nerve. The sound waves that are the reaching to the endolymph through vestibular membrane make the appropriate part of the basilar membrane vibrate, so that the different parts of the organ of corti are stimulated by different frequencies of the sound. This scala tympani, it is related to that of the round window, and the round window membrane, it releases the mechanical energy to the labyrinthine fluid, permitting the movements of the inner ear fluid consecutive to the movement of the stapedial footplate. So that we have seen here that the round window, which is on the medial wall of this middle ear, gives the entry to that of the scala tympani of the cochlea. So here it is the main relation of this round window to the cochlea. From middle ear to inner ear, if we want to get any entry, there are the two important windows, round window and oval window. But oval window, it is covered by that of the footplate of the stapes, while this round window, it will consist of this membrane, tympanic membrane like structure is there. So this round window, it is an important structure from which we can get the entry to the cochlea. So thank you. Thank you, sir.
Just a minute. Hello? Okay. Hello, thank you. Okay, so Dr. Sumit has shown us all about the anatomy of this complex anatomy of this area, and because of the advent of better visual magnification through microscope and further with the autoendoscopes, we are now knowing more names in the on the for the medial wall of the middle ear than we were knowing for the whole of the ear. So, and these are important when you are working in that area. So, and if not in all the cases, but when we come across some difficult situations, some anatomical variations, there this knowledge comes into effect, and it becomes handy, and it helps you to tide over that crisis which one may have during when we encounter the anomalies which are not actually picked up many a times on the radiology itself, because you have seen that how small are the measurements. So like the basal turn of your cochlea is just 5 millimeter from the internal auditory canal. Similarly, your other structures are just like facial nerve 2 millimeters, oval window 2. So this is like everything is within the within a measurement of 5 millimeters when you are working on the cochlea, or you intend to work on the cochlea. So before going further, I would like to you all to see this figure and try to understand that figure, and then we'll go that what is posterior tympanotomy. So posterior tympanotomy today has an indication. It actually started with as a part of combined approach tympanoplasty, where people didn't want to take off the posterior canal wall, and they still wanted to be sure about the clearance of the disease from the sinus tympani area. Okay, so which should be somewhere here. So this is a specimen where the canal wall has been taken down. Okay, so that was the earlier indication. Today, I think it is most of the time a posterior tympanotomy is done for cochlear implantation. And cochlear implantation through posterior tympanotomy approach is a classical and conventional approach which is being followed worldwide. And for so many years, almost it is like 97, if it is, we think that it started in somewhere around 87. So it's almost 35, 40 years that the cochlear implants are being done through this approach. And this is a good approach because it gives you a trajectory same as the trajectory of the cochlear coils, or the this turns of the cochlea. So this is a right ear which we are seeing from behind. So this is superior, this is inferior, and this is the facial nerve. So the posterior canal wall, which would have been here, superior canal wall, which would have been here, has been not totally taken, which would have been here, has been not totally taken down. And what you are seeing is facial nerve, oval window, round window, and then this is your lateral semicircular canal, which you always see when we do a cortical mastoidectomy, the most prominent part which you see, and the most whitish bone which you see when you start doing a cortical mastoidectomy. And this is the basal turn. So you just imagine that your cochlea is like this. This is the basal turn, this is the middle turn, and this is the apical turn. Round window, as Sir Dr. Sumit has told, that every turn has got a spiral lamina, osseous spiral lamina, which is from the medial side. Okay. So this part which has been removed, that means that the lateral part of the lateral wall has been removed. This is the osseous spiral lamina. What all other thing has been removed is the basilar membrane or the organ corti, everything that has been removed. So osseous spiral lamina is something, and in continuity there would have been the basilar membrane. So below that is your scala tympani. Above that is your scala vestibuli. Okay. And this is the round window. So if we go from here, if we insert something from here, we would be entering into the scala tympani. Okay. But then there can be accidental entry into the, we might be injuring the osseous file lamina, accidental entry the vestibuli, that we will discuss. But first thing and the foremost thing that you should always have in your imagination, that how would your cochlea be? Okay. So this is a picture which has been taken just before that, the earlier one. So this is the basal turn, and then that it comes the middle turn, and along the process cochlear formis is the your apical turn. So now we would come to how we would approach this, how we would come to the cochlea, how to insert the electrode into the cochlea. So for that, what we or the world follows is the posterior tympanotomy. So again, this is a right ear. A cortical mastoidectomy has been done. What you are seeing here is the incus. So for posterior tympanotomy, one has to do a cortical, but not if you are doing a cochlear implant. These bony edges are to be kept. They should not be removed fully. So there should remain a small bony overhang, and then you drill into this attic additus area till you start seeing the long process of short process of incus. So once you see the short process of, when you see define the short process of incus, that area is known as fossa incutis. And what the importance of incus is that it shows you the direction of the facial nerve. So if you draw a line longitudinal to this, that would tell you that where your facial nerve would have been. So it is already open. So if you imagine that there is bone, and you draw a line like this, and you draw a line like this, you know that if you are drilling anterior to this line, you are safe. This, again, this arrow is, what is this? This is the chorda tympani. So chorda tympani is exiting somewhere here from the facial nerve, and then it is coming, because you know that it comes back into the middle ear. So for posterior tympanotomy, your landmark, your defining boundaries are superiorly. You have to see the short process of incus. This small bony buttress we preserve most of the time, and then there may be reasons sometimes to remove this bony buttress. But for as far as cochlear implantation is concerned, we do not remove this. But like if you want to do a facial nerve decompression without taking the canal wall down, then you have to take it off, because your facial nerve would be horizontal segment would be somewhere here. You want to remove this bone so that you see the horizontal part. But for implantation, you preserve this buttress, this small buttress of bone. And medially and posteriorly, this is the boundary is facial nerve. Superiorly or laterally it is the chorda tympani, and inferiorly it is the chordofacial angle, facial nerve and the chorda tympani. So it's a triangular area which is bounded superiorly by this bony buttress, inferiorly by the chorda tympani angle, superiorly or the laterally by chorda, medially by. So if you define these areas, you get a size of around 2 to 3 millimeters, and which is good enough to do a cochlear implantation. So once you open up, once you do a posterior tympanotomy, what you start seeing is this a black shadow kind of thing, which is your round window. What you are seeing here is your pyramidal process, and there would be your steppies somewhere here. So this is how do we do a stepwise this thing, posterior tympanotomy. You go to the antrum and additus, define your incus. A bit of incus is being seen here, and then you start drilling in line with that, and you have to go stepwise. I will show Once you see these figures, we'll show you the video also. And once you do a posterior tympanotomy, you start seeing this edge of bone from where a blackish shadow is seen. If it is you are not unable to see, what we do is we put a drop of water over here, and in that we could see the reflections, which gives you an idea that okay, your round window membrane should be somewhere here, and then you see the depth of the round window membrane or the depth of the this bony edge, which you need to remove if you have to see the whole of round window membrane. For cochlear implantation, it is always good to see whole of the round window membrane and then to remove it. So this is how that bony edge which was there is being drilled, and once you drill it, you see that you could see the whole of the round window, and through this what you are seeing is the scala tympani. So this is a video of our one of our cochlear during our cochlear implantation, which is a bit old video. So earlier we used to start with a smaller, very small, say 1 mm burr, but now what we do is we use a slightly bigger burr. So what you are, this is again a right ear, this is superior, this is inferior. What I'm doing here is that this is your incus, your short process of incus. So I know that my facial nerve would be somewhere behind this line. If I draw a line along this, my facial nerve would be behind this line. So I would be drilling somewhere. Again, you need not to go too far superiorly, because if you go too far superiorly, you would actually entering into the you would either drilling into the annulus, or you would actually entering into the external auditory canal, which again you do not want to do. And it is important it's more important when you are planning a cochlear implantation, because if you injure the annulus or if you injure the tympanic membrane, that's not a good sign actually. If you thin the posterior canal wall in continuity with the annulus, that's not good thing, because what happens that at that time it may go unnoticed, but over and over the years, what happens is that the posterior canal wall bone and the annulus gives way from there, and your electrode may come out into the external auditory canal. So what you are seeing is that we have found usually there is a big cell, which big air cell is there. Once you find that, you just have to follow that air cell. Okay. So we have found a air cell here, and we are following sorry, hair cell. We are following that air cell over here. So all the time we are seeing that we should not be what we are drilling, and what is the color of the bone. So once you have drilled the bone over the facial nerve thin enough, you start seeing a pinkish hue, or the small vessels, pinkish hue with small vessels running longitudinally in this direction. So once you see that, you know that okay, now your facial nerve is should be there. So now we have drilled this area, and what you are seeing is that in a moment we'll be entering into the middle ear cavity from this side. So we keep on irrigating when you are doing it in live surgeries, because you do not want your any bony substance to be there in the middle ear when you are opening the cochlea, or you're opening the scala tympani. So now you see that slowly and slowly what we are doing is that we are enlarging enlarging our posterior tympanotomy. And what other thing you should notice is, and it is important when you will be, your dissectors will be with us when you are dissecting, we are not dissecting in this antero-posterior direction anymore. We are dissecting lateral to medial. Okay. The direction of the drill is lateral to medial. मतलब we are We are directing our drill bit towards the medial wall of the middle ear or the middle ear cavity, not towards the, we should not be directing your bit towards the external or the anterior auditory canal, external auditory canal. So slowly when you drill, you will start seeing the, now there is a small glimpse of, once I'll remove my bit, you will see that is a small glimpse of round window membrane. So round window membrane, what happens is that round window membrane, the true round window membrane is actually covered with a pseudo membrane, which is a bit thicker. So to see the true round window membrane, you have to remove the false or the pseudo membrane. And it is not very uncommon to see that pseudo membrane a bit thick, because many a time these kids would have been undergone otitis, acute otitis or otitis. So this is, I'll stop for a while. So this area, what you are seeing is a round window niche area. Okay. And this is that white thing is the bony overhang. So this is one of the most favorable position of the round window. So when you see the literature, you would read something about the rotation of the cochlea. So the direction of this round window niche is not always like this. So it may be directing like this, it may be directing like this. So it depends upon the position or the rotation of the cochlea in the otic capsule. So we'll not be going further into that details, that what is rotation of cochlea, that you can read in your books. So, but this is one of the most favorable position when your round window membrane is seeing towards inferior or inferolaterally, inferoposteriorly. So now you would be seeing, yeah, yes, this is. So this is the bony edge, and that's what you are seeing is the round window membranes. So we'll be drilling a bit of it so that we get the full exposure. So here, when we come here, then we increase our exposure. So what you are seeing here is, this is the pyramidal process, this is the stapedius, and now we are drilling the upper lip or the tegmen of the, a bit of tegmen of round window niche, so that we see the round window in its totality. So now you would be seeing round window very nicely. What, before inserting, what we do is that we drill this area a bit again, because now if it is superior, it is inferior, your scala tympani would be, and here would be your, somewhere here would be your this thing, processus cochleariformis. So your direction of the turns of cochlea would be something like this. So what you want is that your electrode should go like this. Okay, you don't want your electrode to go like this, because superior to it, here would be your osseous spiral lamina, and there would be also your basilar membrane. So you don't want to go into this direction, because in that, if you go into this direction, you will you will be injuring the anatomy of the cochlea. The direction or the trajectory, what trajectory we want is that we should go like this. So if you have to go like this, a bit of this bone has to go, a bit of this also has to go. So earlier what people used to do would, that they would drill somewhere here as bony cochleostomy, and then later people realize that this is not the most favorable position, because it, in those cases, they are sometimes entering into scala vestibuli, sometimes they are also entering into scala media. So then what they started doing is that once they would start seeing the round window membrane, drill a bit of it here, this bone, and then they would insert their electrode, which they used to call soft surgery. But now what is being followed at most of the places with the more detailed anatomy, what we know today is that we define the round window membrane in totality. We remove the round window membrane and then we insert. Sorry, just a minute. So this is how it looks like once you drill it. Okay, so we have drilled a bit of bone here, we have removed a bit of bone here, and maybe we will drill a bit more here so that our electrode doesn't get impacted here when you insert like this. So this is how the round window is prepared before we finally insert our electrode. And once the sufficient bone work has been done, we just remove it with a small needle or a small pick, right angle pick can also be used, which you use for your stapes surgery and all. So once it is done, yes, now you can see the lumen, very well see the lumen of the cochlea. So now it is very well prepared for your insertion and it will go very smoothly. So this is the place till where we have seen. Okay, so it is again the right ear, but the only thing is that your patient is having your head on the right side, or side is this and the low side is this. So this is how. This is okay. Sorry, this is the left ear actually. This is left ear. This is superior. This is inferior. This is the basal turn. This is the middle turn. This is the apical turn. There would have been your stapes foot plate. So now you see that your basal turn is like this. If you draw a line, curved line from the upper boundary of the oval window and go anteriorly like this, and you draw a similar line like this. So this hole is your basal turn, and part of it inferiorly would be your scala tympani, superiorly would be your scala vestibuli, and this thin line which you are seeing is the osseous spiral lamina, where the osseous spiral lamina would have been. So if you see this figure, you will correlate it better. So the lateral wall has been cut like here. This is the osseous spiral lamina. This is your basilar membrane, where your organ of Carti would be laterally, and then your nerves will go towards the center, where they would enter into the modulus. So we want the electrode to remain below this only. We don't want to touch it. We don't want to go across it, and that is why the direction of the electrode is always like this. So if you are like I was telling that if I try to insert like this, if I try to insert like this, what would happen is that I would be entering into the scala tympani like this. Okay. So for that, what has not been done, that this lip has not been removed. That is why we are entering like this. So if we remove this bone, we would not be entering into this area. We would be going inferiorly, which we actually want. Similarly, as I was telling, the posterior part overhang also has to be removed, because if we do not remove, what happens is that your electrode gets stuck somewhere here, or it would, when you insert it, your electrodes will, when you insert it will touch the bone or rub against the bone before entering, which may actually harm your electrodes. So, what we follow and what the world follows today is the insertion through the round window. But still, we need to know that what is bony cochleostomy, because sometimes you may not be actually, with all your efforts, sometimes it becomes difficult to see the round window. But those are very, very, very rare chances. Okay, so say like you do 50, 100 cases, and then you, in one case, you would require a bony cochleostomy. So bony cochleostomy is, again, this is the same cochlea, and when you drill somewhere here is your bony cochleostomy. So drilling antero-inferior to the round window. So what today world follows, wherever they do a bony cochleostomy, they should be drilling into the antero-inferior area. And why antero-inferior? Because if you drill here, you would not be entering into the scala vestibuli, whatever. Either you would not be entering, or if you are entering, you will be entering only into the scala tympani. What earlier they used to do is that they would go to the promontory, the most prominent area, see that where is the lip of the round window, drill somewhere here and insert. And in those cases, when later on, if like those patients, whenever they died, these implant patient died because of any reason, and people have done post-mortems and the sections of their cochlea, what they have found, either it is, sometimes it is in the scala vestibuli, or even in the scala media, they have seen reported the electrodes. So if you drill this area and then you enter, it is. So what is the advantage? Advantage is, written literature says that it gives you greater insertion depth. Greater insertion depth means, if like you are inserting from here, and you are obviously, whatever electrode you are using, your that length of that electrode is fixed. So if you are entering from here, your electrode is, if I say it is reaching up to here, and if you are entering from here, obviously it will reach here. So that is the difference. That difference is actually not the real difference when it comes to the result, because there also, in this area also, there are nerve bundles, there are nerve fibers. So if you are entering from this area you are leaving this area and you are covering this area. If you are leaving, if you are inserting your electrode through round window, you are covering this area, but you are leaving that area. So it is actually inconsequential in terms of long-term results. But yes, it has got a disadvantage, because when you drill the bone directly to enter into it, you might be actually injuring the very delicate anatomy of the inner ear, or the membranous part of the inner ear. And obviously, when you are drilling over here, when we drill here, then we drill till the oval. We have not opened the scala tympani. But when you drill over here, we don't know when you have opened the scala tympani or you have opened the inner ear, and your bone just go inside, and which may in long term cause fibrosis of the cochlear duct. Other thing is that when you drill it, there are chances that whatever residual hearing is there, it may actually be gone. And then injury to ductal reunions is also reported. Ductal reunion, something which opens over here, okay, just below this area. So that injury may also be there. But these are not so important. The main thing is that nowadays there are not too many people who do a bony cochleostomy, until unless they are forced to do because of the anatomy or the pathology which they are dealing with for doing cochlear implantation. So we'll be discussing a lot more about these things when you people will be with us. We will be having the faculty from the other institutes also. So they would be sharing their experiences, and I expect a lot of one-to-one discussion happening over there, and the whole uh, scheme of things have been made like that it should incite you people to think more, read more, and ask more when you, so that you you actually recover each and every penny which you are spending on this course. So that is what our philosophy of our team is. What that is how we think that once we are connecting for an academic event, we should be able to give you the most, and we should be able to give you the most through our other colleagues from other institutes also. So I think it's already I've taken I think 30 minutes. So if there are any questions, I would be happy, and I would say that all of you please see n number of times your Mario Sana before you come over here, because that would help you, and come with a mind that you are going to do the best dissection when you are coming over here. So Dr. Utkal, no, we have never required till date. We have never required to sacrifice the chorda tympani. Yes, you can unmute and ask, please. I'll stop sharing, I think.
Hello, sir. I have a question. Is it necessary that we enter through the round window only? If we like, sometimes if we don't find it, can we enter through the somewhat superiorly, make an opening?
So I would tell that what happens is superiorly means that you want to enter into the middle turn.
Yes, sir.
That is what you want, na?
Yes, sir.
Entering into the middle turn is not a very good idea, because for that you need to understand that how the tonotopicity of the cochlea is. Okay.
Yes, sir.
So all of you who are listening, I would request you to please. There are obviously you can search and you will find that how the tonotopicity is, but the easiest way I would tell you to go to the site of this cochlear implant company, Medal, and then there you would find the how the tonicity of the cochlea is, that which sounds. They are very beautifully, they have very beautifully given the examples of where which sound actually is. Okay.
Okay.
So your high pitch sounds, है ना? So as you start the basal term, there would be your high pitch sound. As you go towards the apex, like the sound of a word would be perceived by your basal tone. That is we know, na?
Yes, sir.
And sound of a cloud would be just a minute, would be perceived by your apical tone. Now what happens is that most of these implants, they are not made to go up to the apex. Okay. The three companies which are FDA approved for whose cochlear implant is FDA approved, two of them, they say that their implant, the length of their implant is to cover 450 degree of the cochlea. Okay.
Okay, sir.
As we know that it is more than 70-20 degree if you consider it as 2.5 ton. Okay. 1 ton is 360 degree. 540 is around one 450 is around 1 4 ton, and 1.5 ton. So the other companies, what they say, this medal says that they cover 540 degree. So if you go from the middle ton, okay, you would be losing a lot of sounds which are more common.
Like the audible ones. No.
Yes.
Okay, sir.
So the quality of sound will be entirely different for the recipient. You will be able to insert maybe a smaller one, because not every area is like you cannot insert into the apex also. Though like medal makes implant which is 31.5. Okay,
Yes, sir.
to tell you this thing also.
Hello.
Yes, yes.
Good morning, sir. Good morning, sir. Sir, I wanted to ask, could you tell something about the Varia technique and how it is different? Because I never
See,
understand it.
I never do varia, and reason being is that one is that trained in posterior tympanotomy. The other is that most of the world follows posterior tympanotomy. And the most important thing is that to me that appears the most physiological. Okay. Because what happens with varia is that you are entering through, you are actually taking a trajectory which is not along the normal trajectory of the cochlea. And I do not think, so I do not follow varia, so do not follow the this thing also. But I do not think that the varia, matlab, I think it's, if you're doing varia technique, you are, I think, forced to do a bonicochleostomy. Round window insertion, I don't think it is, it is, it is frequently possible with the this thing. This is, but yes, that is. Uh, I do not do that, so I do not want to discuss that also actually. So, yeah. So what I was telling is that you go to this thing, na? Yes. I was trying to take just a minute. If we have time, I will. So, opponent to how does it work? Live from. So if you go to the this website of the Medal Cochlear Implant Company, and there you would find what these things which I told, na. You would find that how the cochlea is, how the tonotopicity of the cochlea is, which sound is perceived at which part of the cochlea, and then you would understand that why it is not a good idea. So it is not, it is there in the literature, and there may be some time when you would have to insert through the middle ear, uh, uh, through the middle tongue, and these are the cases of like labyrinthitis ossificans. So part of it has gone into labyrinthitis ossificans, and we find that on the MRI and CT and MRI images, we find that okay, there is some lumen in the middle tongue. So what we do is that we go like 2-3 millimeter anterior to the oval window, drill over there, and from there we insert. So there are a number of things, like there are options of split electrodes where a part of electrode is inserted into the basal tongue and the other part is inserted into the middle tongue. So these are the special scenarios for these special pathologies also, but it is not done. It is not a routine procedure to do actually.
Also, sir, I had one more thing.
Mhm.
Like we have to decide in drop. Okay, like when should we stop it? Like if we are not getting, we are finding it very difficult. Uh, and other things also, other like the interop indications that show that you should not proceed with the things.
It is not that common and it should not be that common. That is why we do a radiology before taking a patient or before we even advise cochlear implant for any patient. So that
Yes, sir.
should not happen too often, but then there may be sometimes very minute anatomical anomalies which are not picked up on the scan in a prospective manner. You would pick those up maybe in a retrospective when we do not find the our landmarks. So that is not that common. But yes, if you are not sure that you are actually seeing into the scala tympani, I would not go ahead with the implant. It is 6 months worldwide. India, it is mostly considered 1 year. In for most of the schemes, it is either 1.5 year or 1 year. Because what is happening today is that in India also most of the cochlear implants are in India. Most of the cochlear implants are so at most of the in most of the states it is either 1 year or 1.5 year. But yes, I think one of these three implants is actually FDA approved for 6 months also. So worldwide they are doing at 6 months also. In fact, we saw on this thing Lion that they were doing even at 3 months of age. But yes, 1 month, 1 year is a relatively safer age for. See, here the issue is that the risk associated with anesthesia, not actually the risk associated with surgery. The risk associated with surgery, you already know that there you need to worry about the facial nerve, which may be a bit lateral and all those things. But the major thing is the anesthesia risk. The smaller the age, the more the anesthesia risk. That is why FDA had earlier capped it at 2 years, then decreased at 1.5 years. So it is not because of the cochlear implant which are improving that the age is getting decreased. It is because of the anesthesia techniques and the anesthesia safety which is improving, because of which the implants of the implant is decreasing. The approved age of the implant by FDA is decreasing. So I think to us 1 year is a safe age actually to do.
So I wanted to ask one more thing. What is the minimum IQ at which a cochlear implant can be done? Or should we avoid it in all cases of mental,
No, 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 no.
subnormal mental
There is
ability?
a lot of literature to suggest today that what is IQ? No, no, IQ is again
The
something.
age.
Somebody is like the people's experience, na. It is their experience which is not being read, which is not being actually. They have not been fed or they have not been taught. So that is all about IQ. So if somebody is not listening, how can we think that their IQ, it may be that their IQ, the way we examine their IQ would be good, but we should not be thinking that their IQ would be say similar to a child, will always be similar to a child who doesn't have, there is literature which says that even the IQ changes when you do a cochlear implant. So cutting off हम लोग जो करते हैं वो हम लोग आईक्यू देखते हैं बट वी कंसीडर along with that how much is the self care, so that part is important. If like child is not is in a stage where he is not able to take self care of himself or is like unaware of the harmful things and all those, there obviously we can avoid, but there is no such criteria to not to do a cochlear implant just because a child psychologist has told us that the IQ of the child is like 60, 50, 70 or something. We do it. And there is enough literature actually to support that.